Okay, so we're gonna go over the next 5 lectures, starting with, we're actually gonna sort of go out of order. So I'm gonna do lecture 25 and then do 24 before we get to the next 3. So we're gonna look at renal diseases and special populations first. So we're gonna talk about peds, pregnancy, genetic factors, and sickle cell. So pediatric H&P looks a little bit different than adult. Nephrogenesis starts with the uteric bud, starting by week 5 and 6. At this point, moms may not know that they're pregnant. So they could be on drugs that increase or have that teratogen risk, like ACE inhibitor or ARB. Neonates can't concentrate their urine as well, so they're prone to volume depletion. So like diet, and they don't respond to ADH. GFR starts really low at 20 mils a minute. And so if we think back to our last lecture, GFR of 20 is going to be, if we were staging it by CKD, that would be stage G4. So that's really bad. But in newborns, it's going to raise to the adult levels of 100 to 130 by age 2. So not a big deal when they're newborns. So oliguria in infants is going to be less than a mil per kilogram per 24 hours. In older adults, it's going to be 0.5 per mil per kg. And then adults is less than 500. So you can see, I wouldn't just like memorize these, but you can like see the difference. Kids, it's like way less than adults. Serum creatinine, as you can tell, it changes too. So if we look at this in micromoles per liter, well, let's look at milligrams per deciliter. This is the normal way to look at it. This is the not normal way to look at it. But 0.3 to 1 is normal in newborns. By the time we get to adolescents, it's 0.5 to 1. So it's very similar, from a newborn to adolescent, but let's look at infants and children. So 0.2 to 0.4, or in children, 0.3 to 0.7. So, you may get a lab back and it says it's normal creatinine, but like you have to take into account that it may be, if it's an infant or child, it may be really high. So like, let's think about an infant, and let's say we get a creatinine back and it's a 1, like that's like almost double the upper limits of normal. So just take that into account. So pediatric AKI, again, we have the prerenal, intrinsic, and postrenal. So we've got decreased fluid to the kidneys. Prerenal, just like our normal stuff. Intrinsic, ATN, think about like the vascular diseases like HUS, caused by E. coli. AIN, glomerulonephritis, postrenal, similar obstruction, and then important one here, there we go, would be posterior urethral valves. And of course, like medications and stuff like that. Okay. Here's just like looking at these again. So we're gonna skip it. Okay, pediatric CKD, the most common cause. Remember, we had 3 things that caused CKD. And one of these causes was congenital abnormalities of the kidney. So most of these are going to be that congenital abnormalities. Decreased urine output could be another cause. surgery, UTI, biopsy. If pediatric hypertension is going to be worked up, it's not common to have hypertension in children. So it's going to be worked up if it's greater than the 95th percentile compared to their height, age, and gender. So if the test question says something about like, you wouldn't have to calculate it, but if it said like it's greater than the 95th percentile, then you know they've got pediatric hypertension. Okay, so looking at definitions, GFR of less than 60 for greater than 3 months, regardless of other markers, or GFR greater than 60 with structural damage, different anatomy or abnormalities like proteinuria, albuminuria, and so on and so forth. Okay, so you don't need to memorize this equation for Dr. Chisel, but you do need to know that this equation is called the modified Schwartz formula, and it exists. So in children, to get a GFR, it's going to be different. It's taking height into effect, and so on and so forth. So just know that it's the modified Schwartz. Okay. Pediatric CKD staging. The staging is that KDIGO guidelines for older than 2. Here's just looking at that same thing all over again. Complication, hypertension. Adults are already going to have hypertension. Kids, probably new onset. Growth retardation because of resistance to growth hormone. Anemia. Remember that, like anemia of chronic disease, bone disease, and then cardiovascular complications like arrhythmia. Okay, so that's it for kids. So pregnancy. So I said that we talked about this last time, and here it is. So physiological changes in pregnancy. Now there's, like moms will say, like eating for 2. You'll like learn in repro all about all the changes in pregnancy, but physiologically, if you think about it, the mom and the baby has to have more blood going to the mom. Now we're having to filter out mom's like urine and blood and babies. So there's going to be an increase in GFR because the mom is filtering mom's and baby's blood. The increased GFR is going to decrease the creatinine. So if you look at a pregnant patient's creatinine and it's in the normal range, they probably have an elevated creatinine. So like this is something I would 100% know. So if we look at this test question and you've got, and you have this like baseline and their creatinine is elevated, but it's still in the normal range, but it's just higher than their baseline, then think about, okay, well, I know that there's already an increase in GFR and there should be a decrease in serum creatinine. So this normal creatinine is probably not normal and it's actually bad. The increased GFR can increase proteinuria. Blood pressure is going to decrease because of estrogen and progesterone being vasodilators. and then there'll be acid-base changes. So if you notice that and this is important for cardio, if you notice that a blood pressure is going to be elevated in pregnancy, then we got like major problems, because just like the serum creatinine, the blood pressure should be lower in pregnancy. A pregnant woman should have low blood pressure, not high blood pressure. So if we see that, we're thinking, okay, we got preeclampsia, we've got problems. And they could easily ask you in either like renal or cardio, like what blood work would you draw next? And that would be, or not draw next, but like what lab value would you collect next, I guess, or order? And that would be a protein urine. So just know how that works. Okay, looking at AKI again, remember 1.5 times the baseline over 7 days, 0.3 increase in serum creatinine over 48 hours, or urine output less than 0.5. But just don't be tricked. It could definitely be a normal creatinine, but if it increases from baseline 1.5 times, or in the week, or it increases 0.3 over 48 hours, then hey, we've got AKI. The best way to diagnose an AKI in pregnancy is a 24-hour creatinine clearance. So it's hard to diagnose AKI because, again, that creatinine might be in the normal range, but it's not normal. So that's why 24-hour creatinine clearance is best. Here's preeclampsia. So the definition is the development of hypertension after 20 weeks and proteinuria greater than 300 milligrams per 24 hours. And it's going to be leading to end organ dysfunction. And once we get into like altered mental status and seizures, then we've switched over to eclampsia. So make sure that you know preeclampsia has that proteinuria greater than 300 and hypertension. Remember, pregnant ladies, they should have low blood pressure. High blood pressure, not normal. Okay, looking at images. Microscopic findings is going to be, we're going to have swollen glomeruli. It's going to be that lobular pattern. You can see these lobes. And then the capillary lumen are going to be obstructed or narrowed. And then there's going to be mesangial swelling and hypertrophy. So we'll have glomerular capillary endotheliosis. You can see this like really pink looking swollen glomeruli. So if you see on the test a pregnant patient, let's say you've got a 24-week gestation woman that presents with proteinuria and a blood pressure of 150 over 95. And they have a history, or let's say 30 weeks ago, their blood pressure in the office was 140 over 90. What do they have? Well, if they had high blood pressure prior to pregnancy, this is like so important because people had the hardest time knowing this last year. So if they already had high blood pressure, they were already diagnosed with hypertension before they became pregnant, it's just chronic hypertension. Like it's not preeclampsia. Like it's just hypertension because they've already had hypertension. You know, so if it's found before 20 weeks and it doesn't resolve with delivery, chronic hypertension. They've got an increased risk of preeclampsia, but like they could have preeclampsia with chronic hypertension, like they already had hypertension. So that's what makes this one. Chronic hypertension with superimposed preeclampsia. Gestational hypertension is a new onset, but they don't have the preeclampsia proteinuria. So like, let's say they got a high blood pressure after 20 weeks, but their protein in their urine is not greater than 300, then, and it goes away after delivery, then it's gestational hypertension, which all puts them at risk for hypertension later. So just make sure you know the difference between these, because don't get confused. Like if they've had a history of hypertension in the past, they still have hypertension today if they're pregnant. If they've never had hypertension before, now they've got a ton of protein in the urine. It's preeclampsia. If they've had hypertension in the past, now we're at after 20 weeks, still have hypertension, and now we got a ton of protein. It's chronic hypertension with superimposed preeclampsia. Just know this stuff. You got it. Okay. BP elevation in pregnant patients. Look for like proteinuria or evidence or signs of end organ dysfunction, like headaches and visual changes, like I know those. Make sure you know when the blood pressure developed. Before, during, like did it go away as soon as like, or was it before pregnancy, or did it just develop? I don't really think this is that important, but APOL1 has been shown as a major risk factor in the development of focal segmental FSGS in African Americans. Okay, sickle cell and renal disease. So we know that like sickle cell can affect multiple parts of the body. So we know that if a patient develops sickle cell crisis, then it all of the blood starts getting all of the sickles, and it starts occluding, something, so they all stick together, and then it's like forming like almost like a clot. So think about it, it could happen in the kidneys too. So we've got sickle cell nephropathy, and it is a glomerular, it's a pathologic lesion with FSGS and vasorectal occlusion. So there's that occlusion. The big major problem, if we're having an occlusion, now we can't filter really well, so we're not able to concentrate the urine. And it can lead to renal papillary necrosis. I don't know like all of these, but I feel like these two kind of make sense with just sickle cell itself. And so secretion of creatinine is going to increase because we're not able to, like, if the kidney can't work, then our creatinine is going to go up. Okay, so sickle cell nephropathy. We can see right here, here's a patient with marked glomerular enlargement and mesangial expansion with sclerosis. There is going to be brown pigment in the urine showing that breakdown of hemoglobin. Okay, now on to 24, diuretics and other active meds. So we've got multiple parts of the kidney. I'm gonna actually switch to switch to a different slide set really quick. No, I'll just stick with this one. Okay. So our proximal tubule, we've got our carbonic anhydrase inhibitors, or our SGLT2 inhibitors. Our ascending loop, we've got our loop diuretics. Our distal loop, we've got our thiazides. And then our collecting duct, we've got aldosterone, antagonist, and vasopressin. Okay, so any diuretic before we get to the collecting duct is going to increase potassium excretion in the urine. So we're going to be left with hypokalemia. If a diuretic works at the collecting tubule, it's going to conserve potassium. And so it's going to be called a potassium sparing diuretic. And so that is going to be, it could cause hyperkalemia. Remember that ACE inhibitors and ARBs can also cause hyperkalemia, so don't combine them with a drug like spironolactone or something that works in this collecting tubule. So just to remember, urine and blood are going to be usually the opposite. So if I have hypokalemia, that means that I've got low potassium in my blood, but I'm going to be getting rid of a lot of potassium in my urine. So the potassium in the urine would be high. If we look at loops right here, we're going to be getting rid of sodium, potassium, hydrogen ion, calcium, magnesium, chloride, a little bicarb, and phosphate. So getting rid of pretty much everything. Mannitol, we are getting rid of like basically everything. So we like lose electrolytes, and it can cause edema and capillary leak, and it can also increase CHF. Contraindications are going to be if the patient can't pee. And it can, but it's used to decrease intraocular or intracranial pressure. Okay, so proximal tubule, we said consisted of SGLT2 or anhydrase inhibitors, and so know that bicarbs are reabsorbed. NHE3 is stimulated by angiotensin and adenosine. It contributes to contraction alkalosis. So here's our carbonic anhydrase inhibitor. And know that this can cause a type 2 renal tubular acidosis. And the way that you can help remember this is acidolamide. So remember that's our carbonic anhydrase inhibitor. Acidolamide causes acidosis. So that acid in both can help you remember that. Okay, so just to look at it again, type 2 renal tubular acidosis is going to be failure of the proximal tubule to reabsorb that filtered bicarb. So we're going to have acidemia with low serum bicarb, but we've got a high urine pH with low potassium. Okay, SGLT2 is going to stop that glucose reabsorption in the proximal tubule. In type 2 diabetes, adverse effects are going to be low volume, hypotension, and hyperkalemia, as well as UTI. It could cause renal failure if the GFR is less than 40. It does help patients lose weight. Adenosine, it binds to A1 receptors and causes constriction of the afferent arterioles, but it decreases GFR through that constriction. It inhibits renin release and activates the NAH exchanger, so the NHE3. Okay, our loops, they work at the NAK2Cl transporter and blocks it. So it is the most potent site for diuretics. And then that calcium CASR sensor is going to inhibit our NAKCl2 when calcium levels are high. So examples of loops are furosemide, ethacrynic acid, butaminide, and torsemide. And they're used for increased edema and hypertension management. Know that they can cause ototoxicity and electrolyte disturbances. So low potassium, low calcium, high magnesium, high uric acid, and an alkalosis. NSAIDs decrease the response to loops due to that decreased renal blood flow. So may not want to put your patient on an NSAID and a loop if you're trying to get rid of edema. May not work as well. Okay, prostaglandins and NSAIDs in the kidney. PGE2 is synthesized in the nephron to maintain renal blood flow, and it antagonizes Ang2 catecholamines and vasopressin. It's going to dilate the glomerular arterioles and increase the excretion of sodium in water. So it's a diuretic and natriuretic effect. When we administer it instead, in a volume depleted patient, it can cause a huge decrease in the GFR. Okay, distal tubule, we'll be thinking about thiazides, and they're going to block our NaCl channel, and it increases serum calcium and decreases it in the urine. So thiazides, H2TZ, metolazone, and chlorthalidone are, again, inhibiting that NCCT in the distal tubule, used a lot for hypertension and edema. It's not used as much for like CHF as a loop diuretic would be. Electrolyte disturbances, just like loops, we have hypokalemia. We've got hyponatremia, but we're going to have high calcium, so hypercalcemia, hyperglycemia, and hyperlipidemia. Only used if a patient has a serum creatinine less than 2 or a creatinine clearance of greater than 30. Again, NSAIDs can reduce their use due to that decreased renal blood flow. So looking at this calcium excretion, loops get rid of calcium, so that means that we've got hypocalcemia, and then thiazides have reduced excretion of calcium, so we'll have hypercalcemia. Okay, type 1 RTA, remember, is shown here. And we've got hypokalemia. It also has hypocituria and hypocalciuria, and it's got a pH of less than 5.5. Okay, the collecting tubule, remember that's where our potassium-sparing diuretics, our aldosterone antagonists are located. And so we're going to have, remember that our aldosterone increases expression of NAK ATPase and ENaC, and then our potassium channels on the lumen. Okay, so that hydrogen ATPase in the alpha cell lead to hydrogen loss and bicarb gain. That's just some physiology review. So potassium-sparing diuretics like amyloid and tramturine is going to block, again, that ENaC channel, and it prevents that potassium loss, so we get that hyperkalemia. Amyloid can be used for lithium-induced diabetes insipidus, which is nephrogenic DI. Don't give a potassium-sparing diuretic with another potassium-sparing drug or potassium. Okay, so spironolactone is the most common, and it is going to block the ability of aldosterone to activate the mineralocorticoid receptor. Uses are going to be edema from heart failure or high aldosterone. Remember, it causes hyperkalemia, and then something bad that we don't want, or like men might complain of, is gynecomastia, and it causes impotence in men. So men probably would not like this drug. Hyperkalemia combined with ACEs, NSAIDs, can reduce the effect of the antagonist, or I'm sorry, with ACE inhibitors or ARBs, of course, don't combine them. And then NSAIDs can reduce the effect. Okay, renal tubular acidosis type 4 is going to be right here where we've been talking about. It's causing, again, acidosis, hyperkalemia. Okay, this is just a review of all of these. And I'm pretty sure you have like another lecture over this. Here's the diuretic class and the special effects. Okay, vasopressin. So vasopressin acts to increase the AMP, inserting of aquaporin channels V2 in the collecting duct. And ADH is going to be secreted when there is the body senses that there's going to be low volume, and so it's going to increase secretion, and so that the kidneys will reabsorb more water instead of peeing it out. Desmopressin is going to be, desmopressin or vasopressin are both drugs that increase the circulating factors of factor 8 and von Willebrand's. And this is used in central diabetes insipidus. It can increase blood pressure because we're increasing the volume. It can cause necrosis and then water intoxication. Okay, so desmopressin. There's a thrombotic risk due to that factor, von Willebrand's factor, factor 8. Hyponatremia, because if you have too much water, then you're going to dilute it out so you can decrease their sodium, so you have to watch that. Some people are allergic. So uses of desmopressin besides central DI is nocturnal enuresis. So sometimes they give this to kids that bedwet, and since they don't have central DI and they make their own ADH, it's really important that you would tell the child to stop drinking water an hour before bedtime, and they can't get up and drink water during the night while taking this drug, so you don't waterlog them, cause water intoxication or hyponatremia. This can also help with hemophilia A or von Willebrand's disease. Okay, opposite. Now we're talking about like SIADH, convaptan and tolvaptan block aquaporin 2 channels so that water can't be absorbed. So we use this in a euvolemic or hypervolemic hyponatremia. It can cause hypotension, hypovolemia. Okay, dopamine is going to be at low dose. It's the D1 receptor and it increases GFR. If we increase the dose, it's going to be, so if we look at it, it's D1, and then increased is going to be beta 1, increased is going to be alpha 1. So at moderate dose, it's going to increase, we're doing beta 1, so we're increasing contractility, increasing heart rate. And then at an even higher dose, alpha 1, we know that activating alpha 1 is going to increase vasoconstriction, so we know that that's going to cause like a increase in blood pressure. So use is going to be heart failure with hypotension or renal failure. Side effects are going to be nausea, vomiting, headache, increased BUN, and increased intraocular pressure. Okay, a dopamine agonist, phenyldopa, is going to increase the AMP in GS coupled transporters. This can be used for natriuresis diuresis, and when kidneys are suffering from really high blood pressure, this can be used. And then side effects are hypotension, flushing, dizziness, hypokalemia, tachycardia, increased intraocular pressure, similar to, of course, what we had just talked about with dopamine. Contraindications are going to be really bad intracranial hemorrhages because we don't want to increase pressure. Or if somebody already has increased intraocular pressure, we don't want to increase it even more. Okay. I know that was a lot. And some of these, the drugs are going to come back next week. So, or not next week, the end of this week. I'm sorry. So don't worry like too much. We're going to kind of go over it yet again. Okay, so we're going to look, we've already talked about polycystic kidney disease last block, but we're going to talk about it again. So Okay, so you know that there's a wide range besides just the regular polycystic kidney disease that you learned with Dr. Wang. But this is just going to be the plain old autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease. Okay, so there's two genotypes, PKD1, PKD2. No, don't be a Stacy and like forget on the test what these stand for. So it's polycystin 1 and 2. Polycystin 1 is transmembrane and polycystin 2 is integral membrane protein. I don't remember if that's like super important, but I do remember, no, you need to know it's polycystin and not just PKD. Simple and complex cysts. Simple cysts are going to have simple cysts versus complex cysts are going to be based on the fluid density and the septation, calcification, size, and shape. And we're going to look at some pictures of these. So patients on dialysis can get multiple cysts, but it's not going to be autosomal dominant polycystic kidney disease because it wasn't a genetic cause. It was due to dialysis. So they're not going to have the other problems that comes with polycystic kidney disease. So you can think like Barry aneurysm, liver cysts, like they're not going to have that because they don't have that genetic component. So let's look at some simple cysts. See how this is all the same color? Right here, all the same color. It's one big cyst. So this is how we know it's a simple cyst. It's got a really thin border around it. So we know that the membrane is thin and then it's all one color. And there's not like a bunch of them. Complex cyst, here's a ultrasound, and we can see that it's got many lobes and septation in it. Let's go over to these. These are better. You can see right here. Let me get it here. Oh, yeah. You can see the septations. It's still pretty, like right here, it's still homogenic, but you can see right here that there's heterogeneity, so different colors. And you can see definitely here, see how there's like bright white versus a darker gray. And you can see these like septations. So that's a complex cyst, which is scarier because it has an increased risk for cancer. So polycystic kidney disease, pretty easy to find. See on a CT, look at all of these cysts. Like you can't even see a normal kidney anymore. You just see, like here's the simple cyst. See how, I mean, you see this big cyst, but you can see the normal kidney architecture with the cortex and the medulla. But here, there's nothing. It's just lots of like little bubbles. And we can see how it extends up into the liver. On ultrasound, same thing. We've got lots of dark cysts showing up. Or we can see how it's normal, and right here it's very cystic. Complications, PKD1 is worse than 2, but they're going to start having a GFR that's going to decline as the cysts enlarge and increase. So they could have infections, increased risk of UTI, hematuria, chronic pain, hypertension, can't concentrate their urine well, uric acid stones, and ruptured cyst. Know that there could be hepatic cyst as well, hernias, and then cardiovascular disease. And then leading cause of death is going to be Berry aneurysm. So the patient's going to present in the second or third decade of life with hypertension that we can't explain. They also may present with hematuria or UTI. And then protein in their urine. So we can see the pathogenesis of this. Okay, autosomal recessive. So remember, autosomal dominant is going to be polysystem 1 and 2. PKHD1 is going to be autosomal recessive, which is fibrocystin or polydectin. So make sure you know those. Complications are going to be hepatobiliary abnormalities like portal hypertension, liver fibrosis, pulmonary hypoplasia. So with all of these, an end-stage renal disease, with our amniotic fluid is going to be low. The baby can't move around a lot. They're not being able to drink at that urine, so they get pulmonary hypoplasia. So looking at pictures, here is ADPKD versus ARPKD. So I think that this looks more like lots of cysts, and this kind of looks like lines. This is just looking at it again. So it's adult onset big cyst, and that these kind of, I still think these kind of look like lines. If it was zoomed out a little bit more. Okay, cilia are going to be on the epithelial cells, and as the fluid comes across, the cilia bend to trigger intracellular processes. Here's looking at other cystic kidney diseases, so don't forget the other one. Medullary sponge disease, it looks just like a sponge. I guess he does cover a few more things, but I guess he covers this one. He doesn't cover all of them that Dr. Long does. But you have nephrocalcinosis and ural stones associated with the sponge disease. So I would know those, like these two. So stones. So nephrocalcinosis is deposition of that calcium salt in the renal parenchyma. As you can see, the calcinosis can be seen on the X-ray. So, so it can be seen on IVP. And we can see right here the calcinosis. Okay, so that was it for our polycystic kidney disease lecture. And now we're going to go through 27 and 28, which is renal manifestations of systemic disease that Dr. Cope went over. So I thought that this was probably the hardest, just because I didn't know how she was going to test. and thought she's sort of picky. She has hard things, but I'll try my best. So we have diabetic nephropathy, HIV-associated nephropathy, lupus nephritis, cardiorenal syndromes, type 1 through 5, primary systemic amyloidosis, and then viral glomerular nephritis. Okay, diabetics. So nephropathy is more common in type 1. Albuminuria is going to happen usually about 15 years after diabetes, and if glucose is controlled and they're on an ACE and ARB, it can be managed. So a clinical presentation is going to be elevated glucose, albumin in the urine, hematuria with a low GFR. Pathology, glomeruli have an increased VEGF-A, so the capillaries are going to increase in length and diameter, and microaneurysms can occur. So make sure that you screen them yearly. Type 1, and then 5 years after diagnosis. Type 2 needs to also be diagnosed at the time. So here's looking at the histology. Remember, there's mesangial expansion and glomerular membrane thickening with podocyte injury. So we get this Kenstel-Wilson lesion. Treatment, make sure that you get their blood sugar under control. Their A1C needs to be less than 7, and treat comorbid condition. Start them on an ACE or ARB and refer to nephrology. Okay, HIV-associated nephropathy. I feel like this was maybe asked. This is a type of SGS, and it is going to be associated with ATN. The clinical presentation, I think that this is like most important for her. Like, she likes these clinical presentations, and then she wants you to know what to do. So significant proteinuria, rapid decreases. So before, with diabetic, they were diagnosed with diabetes, and then 15 years later they started having decreased GFR. Like, this is like lots of protein and rapid decreases. They're not going to have edema or hypertension, which is also different. Make sure that you screen them with a GFR every 6 months, and every year you check a urine analysis for protein. They need to make sure that they start on heart regardless of the CD4 count. If they have proteinuria or hypertension, get them on an ACE or ARB. Prognosis is going to be poor with this. So like, if they have HIV, let's say they're like CD4 count is really high, but they're having that rapid decrease in GFR, and it asks you what the treatment is, and start them on heart. Okay. AKI and CKD in HIV patients. It most commonly happens within 3 months of starting heart. And so that's like the bad thing. It's like, okay, you've got HIV-associated nephropathy, and we have to start heart, but now that you've started this medicine, you should get an AKI. So risk factors are going to be high viral load. Remember, if it's a high viral load, that means that we've got lots of virus. So our CD4 count is going to be low. Sometimes that can be confusing. If older age, comorbidities like anything. Common causes of AKI, sort of like other people, low volume, ATN, and medication toxicity. Okay, lupus. Remember, lupus is going to be complement deposition. So there's going to be anti-nuclear antibodies, ANAs, positive. And lupus nephritis occurs with over half, 60% of those with systemic lupus. So mortality is higher in these patients, and African American women have the worst prognosis. So know that there's complement activation and a inflammatory response. So what type of hypersensitivity is that? Okay, good. So it's going to be a type 3. So remember, like IgE, mast cells, that's going to be type 1. Type 2 is going to be antibodies. Complement is type 3. And type 4 is T cell mediated late reaction. There's 6 classifications. Know that type 4 is that diffuse segmental global, and it's the most common and severe, causing that rapid loss of GFR. They also may have anti-DNA antibodies. Okay, clinical presentation is going to be red blood cells and white blood cell cast in the urine, protein in the urine, high serum creatinine, low GFR, and then an elevated sed rate, or ANA. These are the same. So. And you're going to treat it like you're treating lupus. So immunosuppression, glucocorticoids, and cytotoxic agent. So if I was like looking through these, because I feel like this is like the hardest thing, look at that patient presentation, make sure that you know what the treatment is going to be, and then like no weird facts about it. Like, think, okay, well, it's diffuse segmental global is the most common. They've got all this stuff, or I'm going to treat them with immunosuppression, glucocorticoids, something like that. Cardiorenal syndrome is a condition where heart failure is limited by a decline in renal function. So cardio and then renal. So cardio induces renal symptoms, or renal induces cardio symptoms. Okay, so if we look at the words, we should figure this out. So acute cardiorenal, so it's going to be acute cardio causing acute renal. So I just like, the way I remember this is like literally knowing left to right. And I don't think you had to know it was like type 1, type 2 from what I can remember. You just had to know this name. So a cardio problem that's acute is causing an acute renal problem. So heart failure gets worse, for example. And so then it leads to AKI. So treatment, diuretics, vasodilation. So we want to get rid of our cardio problem, and it's going to improve the renal problem. So if we have worsening renal function after an MI, we're going to have a positive troponin leading to elevated BU and creatinine. Okay, chronic cardiorenal. So we have a chronic cardio problem leading to a chronic renal problem. So like hypertension, diabetes, advanced age can progress it. So if you think about it, it's like, let's say we've got CHF or like hypertension, and it's causing CKD. Treatment, loops, vasodilators. Okay, acute renocardiac. So acute renal problem is causing an acute cardiac problem. So uremia, affecting the contractility of the heart. So hydrate the patient, get rid of bad medications, get rid of the obstruction. They may need dialysis. Okay, chronic renocardiac. So chronic renal problem causes chronic cardiac problem. So CKD leads to decreased cardiac function, for example. So cautiously use ACE inhibitors and ARBs. Okay, so secondary syndromes, anything else would be, the most common would be sepsis, and then diabetes or lupus. So it's acute or chronic disorders causing cardiac and renal problems. So treat the underlying cause. And here's just a quick look at that. So primary systemic amyloidosis is going to be a group of diseases caused by the amyloid, abnormal folding. And how are they detected? You guys know this. Apple green birefringence on Congo red stain. So presentation, fatigue, weight loss, renal impairment. 75% of patients will have proteinuria. Treatment, prednisone, and chemo. Okay, viral glomerular nephropathies or nephritides are going to be Hep B and C. So Hep B is going to be associated with membranous nephropathy. Know that that's what it's associated with. And they present with proteinuria, elevated AST, ALT associated with hepatitis, hypertension, and AKI. They can progress to renal failure, diagnosed with a biopsy and positive serology. And you can prevent with vaccination. Okay. Hep C is going to be a mixed cryoglobulinemia with or without membranoproliferative glomerular nephritis. They're going to have a systemic vasculitis. I would know this like palpable purpura, arthralgias, fevers, neuropathy. And they get that antigen antibody complex that's elevated. So they have that systemic vasculitis. So these are like so different symptoms than everything else. So I feel like that would be easy to ask a question about. They may have polyarteritis nodosa, which can be seen either in Hep C or B, which is fever, weight loss, hypertension, GI involvement, and CRP that's elevated. Okay, know the staging. This is just a review. Know the staging for CKD. Make sure that you'll have a question on the definition of AKI. You don't have to stage it, but make sure that you look at like what he put for and. Like sometimes he'll put and or. Make sure that you know the difference. You know, if it says and, you have to have both. If it says or, either or. Know like BUN creatinine ratio. So if it's high, it's pre-renal. If it's low, or high, like greater than 20-1, pre-renal. Less than 10-1, intrinsic. So make sure that you know that. Know the differences between the AKI types, like what we went over last time. Muddy brown cast may say dysmorphic red blood cell cast, darkly pigmented granular cast, that's ATN. In cholesterol emboli, we're going to see it is a atherogenic cause, and you're going to see eosinophilia on that CBC, so high eosinophils. cholesterol emboli. Heme pigment, but no red blood cells, is going to be rhabdo, and that's a cause of intrarenal AKI. Contrast nephropathy can cause intrarenal intrinsic AKI. Make sure that you look for the radiographic images in CKD, like a tiny shrunken kidney, history of kidney transplant, only one kidney. Make sure you know that. That would be, automatically a cause of CKD, because that's like anatomy variation. You're going to have a question on the cardiovascular complications of CKD, so make sure that you know that as well. Know the vascular classification as a result of CKD MVD. So like accelerated medial calcification, vascular stiffness versus intimal calcification, that's atherosclerotic plaque. Know that if you've got a decreased GFR, it increases phosphorus and increases FGF23. Make sure you know that. Decreasing calcium resulting in increased PTH, which is secondary hyperparathyroidism. Along the lines of CKD MVD, know that you may get a X-ray with a patient with a history of fracture, and know that osteitis fibrosis cystica is a result. Anemia is a complication of loss of EPO made in the peritubular interstitial cells. Make sure that you know where they're located. As a result of CKD, loss of ammonia can cause acidosis seen in CKD. You don't have to know the normal ranges for kids of serum creatinine, but know that the modified Schwartz is what's used to calculate a GFR using serum creatinine. So that is all my slides. So we will meet back on Friday, and I've got 2 more lectures to go over, and they're farm lectures, so it won't be too long. But feel free if you have any questions. I'm more than willing to answer. Thank you.